So tell me if I'm speaking too loudly or too softly. Okay. Right. Too softly. Can't hear you, and you're right in the front. Okay. So the title of this is that better? Okay. So the title of this research project was Challenges with the Diagnosis of Childhood Tuberculosis at a Regional Level Hospital, a retrospective chart review to ascertain delays in diagnosis and the determinants and impact thereof. Okay. Ethical approval was obtained from the University of the Witwatersrand and from the DOH at KZN. So as a background, there is a high incidence of children with TB and mortality in South Africa. And not so proudly, we actually have the highest childhood TB burden globally. The possible reasons for this could be that our adult TB control program is overburdened, or that there may be, that there may be delays in diagnosis and management of pediatric cases. So in several instances, treatment for TB in children is started on a presumptive basis. And there are studies to show that 25% of disseminated TB cases can be asymptomatic or have non-specific signs. And early diagnosis is crucial to improve the mortality and morbidity, and also reduce transmission within the community. So there's actually very little data on delays in TB treatment and diagnosis in children, and I did find one study which was actually done in Tygerberg in 1994. Okay, why is it important to know the determinants of the delays? Well, knowledge of the determinants is important so that we can plan interventions and improve outcomes of individual cases and also for control of the epidemic. So this was a cross-sectional retrospective review of children diagnosed with probable and confirmed TB, but not possible. It was children younger than 14, and the study was carried out at Addington Hospital over a 6-month period from July to December 2013. This included patients that were diagnosed as inpatients and outpatients. The primary endpoint of the study was determining the proportion of children in whom management of TB was delayed and their clinical outcomes. And we'll get to the secondary endpoint just now. So what did we define as delay? And we arbitrarily chose delay as 2 to 4 weeks from the time of first presentation to diagnosis and treatment initiation. And we had 3 groups. So there was no delay, and there was delay of 2 to 4 weeks, and delay greater than 4 weeks. The secondary endpoint was looking at the the issues that resulted in these delays. And here we classified them according to, as caregiver issues, health system issues, and under health system issues we had healthcare worker errors, radiology and laboratory, and then health policy issues. So in terms of our results, over that 6-month period, there were 80 children diagnosed with TB at the facility, and we managed to retrieve records for 59, which was 73.8%. There were a total of 3,142 patients seen at the facility at that point, and the incidence of TB diagnosed inpatient was 2.7 and outpatient 1.6. There was a delay in 19 of the 59 cases, which was 32.2% of the cohort. And all of these 19 cases had previous visits to the study facility. In 18 of the 19 delay cases, which was 94.7%, health system issues played a role. In 6 of the 19 cases, caregiver issues played a role. 14 patients of the cohort were culture positive for TB. The median age of the cohort was 16 months, and the median time to delay was 4 weeks. When we discuss outcomes, we'll mention again that those with more than 4 weeks delay had a significant proportion of chronic respiratory issues. Of note, there was no delay between diagnosis and initiation of treatment. So just simply illustrates the delay versus the 2 to 4 week group and the greater than 4 week group. Okay, so this table shows the health systems related factors identified impacting on time to TB diagnosis in the delayed and no delayed group. And the one that's significant there is the inadequate investigation. So we did things badly across the board in both the delay and no delay groups, but we really didn't investigate the delay groups. Okay, and I put this busy table in here just to illustrate the questions that were on the points that were on the data extraction sheet in terms of history, and it was things like cough, history of cough not R's, duration of cough, and I must admit that at this point when the data extraction sheet was drawn up, I didn't have an appreciation of the fact of acute onset of symptoms, as in a child with just a pneumonia can have TB. This was done in 2013. Okay. This table shows the adequacy of clinical examination in the delay versus the no delay groups. Again, it looks at the things that we looked at on the data extraction sheet when we went through the charts retrospectively. Okay, and investigation. So how adequate were our investigations in both the groups? And there wasn't much significance here. Okay, that's radiology, which was actually a very weak point of the study, so we're just going to skip this slide. Okay, so in terms of results in caregiver, in the 19 delay cases, there were 9 cases where caregiver issues played a role, and some of them overlapped. So in 9 of these cases, they presented late, and in 2, they failed to return for follow-up, and the reasons were inclement weather and that they were not informed about following up. In terms of health policy, 44% of the study cohort, of those 59 cases, had a TB contact. But of that total of patients that had a TB contact, 88.5% were not on IPT. In the delay group, 52.6% of cases had a TB contact, but only 30% of the cases were on IPT. And 80% of the total cohort had not been asked about a social grant. In terms of outcomes, of the 59 patients whose files we managed to retrieve, 47 did follow up at the study site for a period of up to 6 months. 12 were lost to follow-up, although their clinical records indicated that they had been given a follow-up appointment. There were 2 deaths in the no delay group, and the chronic respiratory outcomes were worse in the group that had a more than 4-week delay. This was 72.7% versus 37.5% in the no delay group, with a p-value of 0.038. Okay, so if you look at this, it illustrates that essentially the outcomes were similar, the percentages. However, when we broke it down further, the greater than 4-week delay group did have significant chronic respiratory outcomes. Okay, and this table illustrates that, where we've broken it down to 2 to 4 weeks, greater than 4 weeks, and you'll see that the values are much higher in those who are delayed. There was a delay of more than 4 weeks. Okay, so our study illustrated that there was a substantial delay in a significant proportion of cases in the diagnosis of TB in these children. And this actually impacted on outcome and may impact on risk of continued transmission. So early diagnosis is essential for an effective TB program. Our study also illustrated that healthcare worker issues were seen far more often than caregiver issues. Okay, we found when collecting data that there was grossly inadequate clinical records, and we're not sure if this is a reflection of poor note-keeping and lack of attention to detail. Several of these cases had repeated visits, which actually reflects several missed opportunities. I didn't highlight it earlier, but there were no nutritional assessments done. That was a significant value. And if the failure to thrive was detected, this may have alerted the clinician to investigate for TB. Inadequate history taking and inadequate clinical examination occurred in both the delay and no delay groups. Okay. The lack of investigations is very worrying despite the availability of point of care testing. These were not done in both the groups. HIV testing in the total cohort, 7 patients were not tested for HIV, and of these 7, 6 were in the delay group. Okay. So it seems that we're doing empirical TB therapy, and this may actually be placing a strain on the health system. Caregiver, yes, the community still has limited knowledge of signs and symptoms, and under health system or health policy, we have to upscale our contact tracing and IPT. Again, lack of documentation was a limitation, and that may actually just be a reflection of the poor quality of health care and the reason for our litigation. Okay, the other problem was that patients may have not followed up. They may have actually visited other facilities, and caregiver interviews would have really assisted in establishing this. So recommendations are that we have a standard electronic template. This can be used as a prospective research question. Okay, acknowledgements. Thank you to all children who have TB and have had TB. And the study was inspired by Leighton Emanuel, who actually demised of TB meningitis, my supervisors. And those are just a few of the references that I've mentioned in this presentation, but it's not the comprehensive list.
Any questions? No questions? Perfectly understood.